place where the pathology department has expanded. And I came out of industry back here where I had trained here. And when the president had this place built, he asked if I would supervise this place, direct it, and create an accelerator for spawning new companies. So I said I would do it if he would give me the second floor to build a new molecular genetics lab and a bioinformatics lab. So that's part of what you'll see on the second floor. On the third floor is the Innovation Center, and because I'm a neuropathologist, we named it the MIND, the Medical Innovation and New Discovery Center. And it has a TED theater, it has a creativity garage, and it has an igloo village to incubate and accelerate new small companies. So the idea would be, for instance, if somebody developed a laboratory-developed test in our molecular genetics lab, they could instantly create a new company. And this institution is very good about, even if you develop the product here at the institution, you get to keep 40% of the revenue, which is, at other institutions when I was in industry, people used to get 4 to 5% of the proceeds if you developed it on their campus using their resources, so that's pretty good. So the reason why molecular genetics is because, as you know, molecular pathology is really becoming the future of pathology. It's revolutionizing everything that we do. Testing is largely going to next-gen sequencing. Microbiology is all going to PCR right now, probably going to next-gen sequencing too. There's a lot of point-of-care testing and everything, so we want our residents to be well-trained in the future. The other area that's a boom is digital imaging. And you'll see right next to our molecular genetics lab, we have a bioinformatics team. We have an anatomage table to teach gross anatomy. It also will teach disease states, but we'll display a whole body. So our Virtopsy initiative, which is a virtual autopsy, well then those images can be displayed full body. Right now we look at them on regular computer screens, and the Virtopsy is the, once somebody dies, we get permission for an autopsy. We scan the entire body in a CAT scanner, we have a protocol, and then the radiologist does a read and then gives the report to the pathologist. If we're doing a study to see what difference, the radiologist doesn't tell the pathologist, but if it's just a routine, the radiologist will tell the pathologist what they see, and then most of the time we'll go through with a full autopsy and do a comparison of what we see. Usually they see things we don't, we see things they don't. The past 2 weeks we've had 2 interesting cases. We had one case where a guy had significant heart disease and he died. Family agreed to a chest-only autopsy, but we did the Virtopsy first and found he ruptured an aneurysm in his head, and that was the cause of death. Had we not done the Virtopsy, they would have just done the heart, probably found some chronic heart disease, and then had an undetermined death. This way we found out the real cause of death. This week, a 19-year-old died in a motor vehicle accident. The family refused the medical examiner from obtaining an autopsy. They went to court. We offered the compromise of a Virtopsy to the family, and they agreed, and found multiple traumatic injuries to the brain, which killed the kids. So the medical examiner accepted the Virtopsy alone as the autopsy. And I think you're going to start to see that happening more and more as people are less and less interested in full autopsies. The autopsy rate's pretty dismal. That the Virtopsy, especially in forensics, is going to become maybe the standard of care. So we do that too, so we have that. And then in our bioinformatics, we also have a digital imaging system. We did all the product validation for General Electric's healthcare whole slide digital imaging product. So we have a unit here that will digitize whole slides in 3 dimensions. So you do the X, Y, and then you do 9 Z planes, and then you fuse that image so you can focus right on the computer screen. The goal is to get rid of slides altogether and have our pathologists interpret images off of the computer. This gives you tremendous flexibility to whiz images around to specialists, gives you the flexibility to call from home, to work from home, work from your iPad. That would be the thing that pathology needs to catch up, because we're not part of the digital record really with just a report, but we need our images digitized and accessible for conferences and that kind of stuff. Plus, there's a lot of things you can do with image analysis that you can't really do in microscopy. You can feature extract, you can do all kinds of pattern recognition analytics, which is really good. Plus, it can make your life easier. If a computer can count the mitotic figures and you don't have to go to multiple high-power fields and count mitotic figures, not only is it easier, it's more accurate. The other thing is you're not going to miss tissue on a slide, because when you look at a glass slide, your eyes dart around, your hands dart around, you don't really look at the entire tissue. The computer tracks where you've looked and can tell you what you missed. So I think the quality is going to be dramatically improved. So we have expertise in digital pathology, digital imaging, whole slide imaging. We have expertise in molecular genetics, and those are two big fields that future pathologists need to know. So I think you're going to get a good education if you come here, good training. And then we also have a brand new clinical pathology lab being built. It's the first time since 1964. It will be state of the art. It will have automated specimen tracking with barcode. I don't know if you've ever seen how the tracks work, but the machines are all on like a highway. And the specimens get put in these radiofrequency pucks, and the pucks know where to go based on the test, and the tubes and things are barcoded. And so if the machines are here and here, the tracking system will put them in the outer lanes so that they can go off like this. The old systems then would have backups and have to wait for the machines that were down there. But the new systems have like multiple lane highways, so the radiofrequency pucks will pass and go down to the distal machines so that things are sped up and much more efficient. So we're building a brand new laboratory in our brand new cancer center, which would be done after your first year. So your clinical pathology experience would be in a state-of-the-art lab. And then the last thing is we're opening up this spring a $20 million cord blood center, which will take umbilical cord blood, spin it down, and have stem cells for transplants and for research purposes. Transplants largely for hematologic disorders, but a lot of the research is being done now on neurodegenerative disorders and other disorders that these stem cells somehow find their way to go to the area of need and repair it. So I think overall, to have a training program that's medium-sized, that has a university hospital, community hospital, lots of outreach hospitals, molecular genetics, brand new lab, digital imaging, brand new lab, cord blood, brand new lab, clinical pathology, brand new lab coming, you're going to get a phenomenal exposure to what the future of pathology is going to be. Got all that? Mm-hmm. Okay. So I'll give you a tour and open this up to any questions right now. Do you have any specific